Hello everyone. Today I'll be discussing about a case scenario, which is a 32-year-old male who has presented to us with dyspnea, ascites, and pedal edema for 2 months, and his echo was suggestive of a restrictive physiology. So he has a past history of pulmonary tuberculosis for which he was treated 2 years back. Now, how would a cardiac catheterization would help us arriving at the diagnosis? That's what we are going to discuss today in our discussion. So based on the findings and the echo finding of restrictive physiology, what we'll have is in our minds is a constrictive pericarditis versus a restrictive cardiomyopathy. And since he's having a past history of tuberculosis, we'll always think of a constrictive pericarditis also in our case. Why is it important to differentiate between them? Because constrictive pericarditis is a has a potentially reversible cause. It can be treated surgically, whereas restrictive cardiomyopathy has very limited therapeutic options. Now, both of them they result in impaired ventricular feeling, and they both present with a similar kind of clinical manifestations, predominantly right heart failure with preserved ejection fraction. So both of them can give rise to clinical features which were there in our case, that is dyspnea with ascites, pedal edema. The both can present in this way. So before starting directly onto cardiac catheterization findings, we'll first discuss what are the normal cardiac hemodynamics to understand better cardiac findings, catheterization findings in our case. So we'll discuss shortly about normal cardiac hemodynamics. So the diastolic filling is what we are going to discuss today. Diastolic filling depends upon two factors, mainly ones which are extrinsic to cardiac chamber and the intrinsic myocardial properties. The extrinsic to cardiac chambers are the loading conditions which are imposed upon the heart, the pericardial restraint, the chest geometry, and the intrinsic myocardial properties include the myocardial stiffness and the viscoelastic forces. So ventricular diastole, it's a complex sequence of interrelated events, and it is divided into basically three components. A phase of early rapid filling, where you have ventricular relaxation. There is a driving pressure gradient across the mitral valve, forcing the blood from LA to LV. There is a pericardial restraint and myocardial stiffness. Now, why I have focused on pericardial restraint is this in initial phase, the pericardial restraint is minimal. So in constrictive pericarditis, the initial rapid filling will be a steep one. Then there is another phase where there is late diastolic filling, where there is a continuous ventricular relaxation, there is pericardial restraint, and interventricular interactions are acting at this phase. And the final phase is atrial contraction. A diastolic dysfunction is the hallmark of both elevated ventricular fillings and mean elevated atrial pressures are found in both of them. In constrictive pericarditis, the early rapid phase is preserved because the pericardial constraint it starts just after the early rapid filling has started. And in restrictive cardiomyopathy, there is a pan-diastolic impairment. So this is a nice diagram to show the diastolic through the diastology. You can say the diastolic phases of filling of the ventricle. First, there is an interventricular relaxation time where there is no filling and the ventricles are relaxed, and the phase of rapid filling where there is a pressure gradient between LA and LV, and that drives the early rapid phase. And then there is a phase of diastasis and equalization of pressure, and the final phase of atrial contraction, and the final phase of filling in diastole. Now, how does respiratory variation affect on this hemodynamics? So pericardium, it encompasses both the ventricles, RA and most of LA. And we all know SVC and IVC are not intrathoracic. So they are largely unaffected by these swings in the intrathoracic pressure. Now what happens is during inspiration, there is a drop in the intrathoracic pressure, which is transmitted to the cardiac chambers and pulmonary veins. But there is no given change in systemic venous pressure. So there is a gradient in the right heart filling. So this will cause an increased right heart filling in inspiration. And these pulmonary veins are entirely intrathoracic, and therefore the pressure which is reduced in the cardiac chambers is also uniformly decreased within the pulmonary veins. So the left-sided filling does not significantly alter during inspiration or expiration. However, during expiration, the right heart filling decreases relative to inspiration, and therefore the left heart filling remains relatively constant. So what will happen in constrictive physiology or constrictive cardiomyopathy? The primary hemodynamic consequence is limitation of blood flow, blood volume that can be accommodated by the heart during diastole. There is equalization of right and left sided cardiac filling pressures. What happens is, because of the rigid pericardium, it isolates the cardiac chamber from intrathoracic pressure swings, which were earlier transmitted to the cardiac chambers. Now they are unable to transmit. So this causes an of uh, under transmission of reduced intrathoracic pressures to the cardiac chambers during inspiration. Now, inspiratory reduction in the pulmonary capillary and venous pressure reduces the flow between the pulmonary veins and the left-sided cardiac chambers. This rigid pericardium with a relatively fixed intrapericardial volume reduces the LV filling, allowing for an increased RV filling. This is accompanied by an inspiratory interventricular septal motion towards the LV, which we can see as a septal bounce if we have done the echo. And the reverse is seen in expiration. So with expiration, there is rise in intrathoracic pressures, and this augments the flow in left heart. The increased left heart filling with the fixed total intrapericardial volume, which is found in constrictive pericarditis, is pushes the interventricular septum towards right, and thus reducing RV filling and creating an expiratory diastolic flow reversal, which is again transmitted back into the IVC and the hepatic veins. So you will find an expiratory flow reversal in hepatic veins and IVC in constrictive pericarditis. So this is a schematic diagram which shows the changes with respiratory variation. There is with the inspiration, there is an increased filling in the right sided, and the septum is shifted towards the left side. And in expiration, the increased filling occurs in the left side, and thus the septum shift towards the opposite side. And this is also recorded as an reversed uh, flow reversal in hepatic veins. So if you see, uh, if I summarize it, there's a inelastic and thickened pericardium with the reduced compliance. It results in a fixed pericardial volume and a mid-diastolic restraint. It fails to accumulate the increase in venous return, and the ventricles accommodate the increased venous return by the shift of IVS towards the other ventricle. Then there is dissociation of thoracic and cardiac pressures. In inspiration, the PCWP is reduced and the LV diastolic pressure is not reduced, causing a reduced LV filling during inspiration. And this results in an exaggerated ventricular interdependence and ventricular discordance. Again, further discussing the accentuated early rapid filling, as I already mentioned, the early rapid filling is accentuated in constrictive pericarditis. It occurs because there is high driving force and unimpeded early ventricular relaxation. The ventricles are free to relax in the early phase in constrictive pericarditis, and this is followed by a sudden rapid rise in pressure by the further pericardial restraint. Now, this results in a rapid Y descent and a square root sign on ventricular pressure, which we'll further see. Again, in constrictive pericarditis, there is preserved atrial relaxation as well as an exaggerated ventricular longitudinal contraction, which is preserved because the ventricular muscle is preserved. As a result of which, there is an exaggerated X descent on the atrial pressure tracings. So this is a diagram which nicely shows you that there is a Y prominent Y descent as well as a exaggerated or prominent X descent, which is found in constrictive pericarditis. That's because there is an early rapid filling and preserved ventricular contraction. This is another sign, that is dip and plateau sign or square root sign, where there is a early rapid filling and a dip, uh, early dip and a sharp dip, which is observed in constrictive pericarditis. The the dip more than 7 mm is characteristically seen in constrictive pericarditis, and usually this early rapid filling is also observed in restrictive cardiomyopathy, but more than 7 millimeters of mercury suggests more in favor of constrictive pericarditis. Again, as I have already mentioned, during inspiration, the RV pressures are high and the LV pressures reduces because there is ventricular discordance in constrictive pericarditis. And in expiration, the LV pressure rises and the RV pressures goes down. Now this is known as ventricular discordance. So from here, what there is a systolic area index which is measured by area, calculating the area of RV versus upon LV area in inspiration, divided by RV area by LV area in expiration. So you expect this to be more than 1 at least, to be found in constrictive pericarditis. So more than 1.1, the index is significantly higher in constrictive pericarditis compared to restrictive cardiomyopathy. A ratio of more than 1.1 is sensitive to the point of 97% and is accurate up to almost specificity of 100% to identify constrictive pericarditis. So it's very important to, while doing cardiac catheterization, to measure simultaneous pressure gradients of LV and RV and inspiratory and expiratory recordings, and calculate the area and measure the systolic area index. Now, what happens in restrictive cardiomyopathy? See this, unlike the complex interplay of pulmonary and systemic pressures which are associated with constrictive pericarditis, restrictive cardiomyopathy is something which is intrinsic to the myocardium, and they are not changed with respiration. And as with constrictive pericarditis, there is early rapid filling in early diastole because of the high atrial pressures, but it is followed by limitation in filling from the stiff myocardium. This results in a prominent Y descent on atrial pressure curves as well as the square root sign. The stiff, non-compliant ventricles are unable to easily accept the additional increment on volume during atrial contraction, and thus the contribution from atrial contraction is very minimal. So here you can see the tracing. There is a prominent Y descent, but the X descent is blunted because the ventricular longitudinal contraction here is blunted because the myocardium is involved. Also, the atrial muscle are also maybe involved in restrictive cardiomyopathy, and hence the X descent is blunted. Now, this is one of the chief difference between the two. As I have told, the X descent is blunted given because the poor atrial relaxation and increased venous flow in inspiration is unable to be accommodated by a non-compliant RV, and there is a diastolic flow reversal in hepatic vein with inspiration. So what we have seen, a diastolic flow reversal with expiration in constrictive pericarditis, with inspiration it occurs in restrictive cardiomyopathy. And there is no discordance in intracavitary and intrathoracic pressures in constrictive cardiomyopathy. So here you can see the discordance which was very apparent in constrictive pericarditis is not seen in restrictive cardiomyopathy. So while doing catheterization, it both disease, it does demonstrate a rapid early diastolic filling with elevated and equalization of end diastolic pressures. Now, although there is a presence of pulmonary hypertension, which usually favors restrictive cardiomyopathy, almost a third of patients with constrictive pericarditis will also have pulmonary hypertension. And after brisk early filling, ventricular pressure rises rapidly as pericardial constraining volume is reached, and this result in a square root or a dip and plateau sign. This can be seen in both. I have already mentioned in constrictive pericarditis as well as restrictive cardiomyopathy, but a LV rapid filling wave, which we have seen with the height of more than 7 mm, it favors constrictive pericarditis. Now, Kusumol sign, which is quantified as less than 5 mm decrease in the inspiratory RA pressure, is present in both but a disproportionate abnormalities of diastolic dysfunction. It results in a ratio of RVDP to RVSP of greater than 1:3 in constrictive pericarditis. Equalization of diastolic pressures results from the fixed pericardial volume and increased interventricular dependence. So this equalization of pressure that is less than 3, almost less than 3 will be finding in constrictive pericarditis, while LVEDP will be more than RVEDP in restrictive cardiomyopathy by more than 4 or 5 of Hg. So if you see this meta-analysis where they had seen the difference between these two parameters, where, as I already mentioned, the LVDP minus RVDP greater than or equal to 4 will suggest more of restrictive cardiomyopathy, but it's not that constrictive pericarditis patients won't be having or will always be having this or the other criteria. Again, RV-EDP by RV systolic pressure of greater than 1/3 will be having more in patients with constrictive pericarditis than restrictive cardiomyopathy, but it's not a dictum. And you have to correlate everything when you are assessing the patient. So to summarize, in constrictive pericarditis, there is a prominent Y descent which is present in both, but the X descent is present in constrictive pericarditis, whereas in it's blunted in restrictive cardiomyopathy. Equalization of the pressures are more commonly found in constrictive pericarditis, whereas the LVDP is slightly raised than RVDP by 5 in restrictive cardiomyopathy. The square root sign is definitely seen in both, but it's more exaggerated and more uh, the right ventricular filling wave of greater than 7 is found in constrictive pericarditis. The filling pressures of greater than 25 are common in restrictive cardiomyopathy, and hence the pulmonary artery systolic pressure is also higher in restrictive cardiomyopathy. LVDP by RV systolic pressure is more than 1/3. It suggests constrictive pericarditis. LV by RV interdependence, and probably this is the most important sign which we have to elucidate during hemodynamics of restrictive physiology. The LV-RV interdependence, it's discordant in constrictive pericarditis and concordance in restrictive cardiomyopathy. Now, this is again a chart which shows some of the Doppler findings where there is a respiratory variation in the mitral inflow velocity, which is found in constrictive pericarditis. Then the ventricular wall thickness will be increased in restrictive cardiomyopathy. The pericardial thickness may be found increased in constrictive pericarditis. The atrial size, the classical biatrial enlargement is seen in restrictive cardiomyopathy. The septal bounds, as we have discussed, is present in constrictive pericarditis. The most probably the most important sign in echo is the Doppler E prime velocity, which is in the medial E dash is more than 9, is more suggestive of constrictive pericarditis rather than restrictive cardiomyopathy, because this is the sign of the myocardial muscle uh, involvement or not. So the restrictive cardiomyopathy, generally the E prime velocities are on the lower side. And the systolic area index is probably the most specific sign to differentiate the two. But there are some caveats, like if you are not finding hemodynamics, then maybe you can consider effusive constrictive pericarditis pattern. Obviously, atrial fibrillation will interfere with our assessment, and an AV groove constriction can cause a disproportionate rise in LA pressure and PCWP. So you have to look for this caveat, and many a times you have to give a fluid challenge if the patient is grossly hypovolemic also before doing cardiac catheterization. Thank you.